All right. You see my t-shirt? Can you see that? What does that say?
Yeah, RPSCT.
Yeah.
That's a
Cool,
good.
Go.
sir. Cool
That's a
Huh?
po.
good.
Uh-huh.
Cool
Uh,
po.
What's that, Isa?
Very cool po, sir.
Yeah. RPSCT. Amazon. Meron sa Amazon.
Meron na.
Yeah, I think we should design our own and sell it. So let's do this. This is brief. This is quick, right? So what you need to do is let me get a pen. Pen is the best, but I don't think I have one. Maybe I have to look for it. But so the most important thing is like a basketball, okay? I'll show you why. Because once you remember a basketball, it's a lot easier to hook up. So let me share my screen real quick. Can you see the basketball?
Oh, yes.
Okay.
Yes, sir.
So if this was the person's head, think of this as the nose on the front, right? Or even at the bottom, but just think of it as the nose on the front, and then your ear here to the right and ear to the left. Okay. First thing you're going to do is what? Nation to Inyan, right? So from the top or from the nose to the back of the head. You're going to do a cross, right? You're going to do a what? A cross, right? So nation to Inyan from the nose, the bridge of the nose, into the back of the head where there's that bulge, which is the base of the skull. And then you're going to go pre-auricular to from right to the left or left to the right, right? But you're going from ear to ear. So you're going to create a cross. You got it? Once you finish the cross, then you're going to go from the parasagittal. Ito, parasagittal. Okay? And then parasagittal on the left and on the right, or right on the left. And then the very last one is the transverse sagittal, transverse parasagittal, which will go across the forehead, okay, from F7 to F8, but it will touch the FZ. And then you will do the same on the back of the head. It will touch the T5 to T6 running across what? PZ. Okay? You get that? What it will, what we are trying to accomplish is this. Let me show you. So this is what we're trying to accomplish. Can you see that?
Yes, sir.
Right?
Oh, yeah, yeah.
Yeah. So does it make sense? Does it make sense now?
Oh,
So
yes.
what?
Sir,
Go ahead. You can ask any question.
it looks like the basketball.
Yeah, it looks like a
Ball.
basketball. In fact, let me pull it out again so you'll see, right? I'll go right beside it. Oh, ang gulo, sorry. Yeah. Can you see? Side by side, kind of.
Yes,
So
yes po.
you're going from this way, you can't forget. You're going from Nation to Indian, right? So once you get Nation to Indian, you're gonna get your baseline. You're going to do a cross, right? Cross muna. Okay, once you do the cross, nation to Indian, then you're going to go ear to ear. Once you have these two, you'll be able to get, your FPZ, right? You're going to get your CZ, you're going to get your OZ. Okay? That's how it will start. When you get your auricular to auricular, you'll be able to get your T3, right? You'll be able to get your CZ again, and then your T4. So once you finish the cross, you're going to do the parasagittal, which will run from FP2 to C4 and O2. Okay, you're going to create this line. And that's when you're able to, I'm sorry, I skipped. Okay, once you finish the cross, okay, let me go back. Once you finish the cross, right, nation to Indian, auricular to auricular, then you're going to do a circle, all right, a circle. So if you look at the basketball, right, north to south, right, then you're going to create your cross, and then you're going to go circular. Once you get the circular line, that's when you have a landmark to catch your FP2, FAT4, all the way around. Okay? So once you get your circle, then you're going to get your FP2 and then run it across C4 to O2. You'll be able to then get, these other markers. Okay? And then you'll do the same on the other side. Once you finish that, once you finish your parasagittal, you're going to do transverse parasagittal, which will go from F7 to F8. And that's when you'll catch and end up crossing lines to get your F3 and F4. When you do the same thing at the back, it will cross from T5 to T6. But you have to put the marker or the tape on the PZ so you can get the P3 and P4. Okay? Any questions?
Not so far.
Okay, but something's wrong here though. Ignore these 20%. It's not 20%. This cross-seat transverse parasagittal is not 20%. That's actually 25%. But I'll teach. I'll explain. But the main idea is for you to create the what? What did I say? What's the first thing you need to do?
The
Sir,
cross.
first po, cross.
The cross and then what?
Then, circle around, sir, the
Yes,
circumference.
circumference. Good. And then what?
Then,
Parasagittal.
sagittal, sir.
Yes,
Yeah,
para sagittal.
parasagittal.
Yes. So
Parasagittal.
right and left, and then transverse, which is the same. It's kind of like a curve, right? So that's how you'll do it. And then you get everything. All right. And now let me show you. There's no questions, and then let me show you how we get that done. All right. Let me stop share. Let me just grab if I can find a pen real quick here. Okay. All right. Can you see me?
Yes po.
So got your wax pen, right? Or what do they call this? Sharpie. It's a Sharpie, wax marker. So you're gonna get there you go. Hi, Isa. You got ResMed. I have Philips. So this is what we need to do. Nose to nose first. So make sure you're on centimeters, right? Bridge of the nose. always put that 0 on the bridge of the nose. Use your pinky, okay? Once you have it there, use your pinky, ganyan. And so that you can stabilize. There, see how stable? Then you can really go and feel the back of the head. And usually at the back of the head, there's a notch, right? Because that's the base of the skull. So when you get that, you will see now your measurement. Mine is around 35 centimeter. So once you get that, you measure right there on 35 or whatever you can, put both lines so that, okay, so that's your first line right there. I got mine right here. All right? Okay, blue lang yun sa'yo. Dapat meron ka bang red marker? May nakikita mo? Can you
Blue
see
din,
it?
sir, yun.
Okay, good. Yeah, you can still see it. All right, good. So you got Asian and Indian. Okay. All right. So now, next is ear to ear, right? So on the
Yes po.
ear, so you see this fold, right? Where it folds right here, right there, where it folds.
Okay.
Yes, at the bottom of that, right there, right where it ends. Yeah, right
There.
there. Yeah, right there. So let me mark mine. You see? Yeah, right there. Exactly. So you're going to, by the way, by the way, there's one thing I didn't say is when you get your Asian to Indian, right? And you're sure it's in the center of the head, right? Mark that. Mark something there that's on the very center. Okay? Mark the top also. Just the top. All right? So that you have a line there. So when you got it? Good. So now when you get the preauricular to periauricular, you go from ear to ear. Mine is 37. Okay. Now, so 37 divided by 2. So it's 18.5, right? 37 divided by 2 is 18.5. So I will find that here. My 18.5 is right here, right? So I mark that. That's halfway. Okay. So now I have that cross. I have a cross now on CZ. Okay. So measure yours. If yours is, what's your measurement, Isa? From ear to ear?
Sir, mine po is 40 po.
40. So you mark right at 20. Mark it right at 20 cm. Okay. So that's your
Okay
middle.
po.
That will be your CZ. Yeah.
Yes po.
So now we have a cross, right? So now Now, I'm just trying to get you to do the cross. Now let's actually measure the markers. Let's go back. Let's go back to our nation Indian, right? So mine is 35. So what is 10%? What is your measurement, Lisa?
Sir, mine po 37 po.
So what's 10%? It's 3.7, right? So,
3.7.
so from the nation, right? Hold on to that. Mark your 3.7 spot. I will mark 3.5 because mine is 35. So mark on both sides, right? And then draw a line, right? So now you got that, and I go back. You got your front. Now I'm going to the OZ, and I will mark my 3.5, right? So now here I got my OZ. And this one is my FPZ, right? So, okay, look at this is my OZ, my FPZ and OZ, right? Because that's 10% of your measurement, right? That's why they call it 1020, right? So now, for you, since you got 3.7, you go now to that marker of your FPZ. You put your 0 there, right? And then from there, make sure that it's on the center of the head, okay? So now you're going to get 20% of that from FPZ to FZ. So you 3.7, 37, 20% you just multiply by 2. All right? So 10% for you is 3.7. Now times 2, you have 7.4, correct?
7.4.
So now
Yes
you
po.
find that 7.4 and mark it. Mine is 3.5, so I got 7. All right? So you mark that 7. All right? And you should actually, when you mark 7, that is your FZ. All right? You got your FZ. And from FZ, you go back to the center. If you mark another 7.4, that should be your CZ. Okay? And you can mark there also from your CZ back to the back, going to the back of the head, mark another 7.4. That will be your what? That's your PZ.
Easy.
Yes. So you got your CZ, you got your FZ, PZ, OZ. And the very front is FPZ, right? So now you got the markers. All right? Following along. You're doing good.
Yes, sir.
Okay. So now that we have all our Z's, right? You got your, what again? FPZ or prefrontal.
FTC.
That's where we usually put
Opo.
the what? What electrode? The ground, right?
Yes, sir.
Yeah, that's where you usually put your ground or your reference. And then you got your FZ, your CZ, PZ, and OZ. Got it. Now let's go ear to ear. So ear to ear, what's your measurement? But now, remember this. You're going to make sure that use your pinky, put the 0 on the line of the auricular. Okay, hold it with your pinky and make sure that you cross the CZ in the center. Okay? If you look at my tape, I put it right on top of the line of the CZ, then I put my thumb over. So see how I'm secure right here, Isa? Look at my hand here. It's secured, right? Now I can just pull my tape and go all the way to the other ear, which is mine is 37. What is yours?
30, 39.5, sir.
Okay. So you can actually go 4, right? 40 for 40. But if you want to
40.
go,
Uh-huh.
yeah, so what you'll do now is to get 10% of that. So mine is 37, so 3.7. So you mark from the ear, all right? 3.7, and yours will be 4, right? Now,
Okay po.
now make it longer so you can easily see it, right? So when I mark, I make it longer. Look at my mark. It's a little bit long, so you can quickly spot it. Once you become used to this, you can make it small because you every time you measure, it's gonna be the same. Yeah, there we go. That's good. So now that's your, what is that? This will be your temporal. So this is a T, what? On the right side?
Three.
Yeah, T3
Right
on the
side,
left,
sir.
T4. Yeah,
Left.
you got it.
T4 on the left.
So now that's 10%, right? So what do you think is next? You put your zero measurement on the T4 or T3, then you continue with 20%, right? So 20% of 4 is 40 is 8. You should mark 8 minus 37. So I would put 3.7 is 7.4. Okay, now I mark at 7.4, right? Yeah. Now go 20% above T3. That will be your C3,
E.
right?
Yes,
Yeah.
sir.
But when you look, Isa, when you measure from your auricular, 10%, and then 20% for your this is your T3, T4 now, right? And you go 20%, that you will get your C3, C4, right? Now
Yes.
what you do is you go to the other side and measure. Don't continue from one side down here. It's going to be skewed. You have to go from this side now, minus 3.7, right? Yours will be 4.0 or 3.95. Then you get your other T. Then I will go 7.4. All right. But make sure again that your tape is heading towards C3, right? If your tape is kind of all over, you will get really messed up measurement. Make sure that you always put it on the line of the C3 or CZ. So everything will be balanced. Now that I have do you have yours now? Your C3, C4?
Yes,
Yep.
po.
Very good.
C3, C4.
Right. There we go. So now we finished the cross, right? You finished the cross. And trust me, when you get used to this will take you maybe 5 minutes or less. Just so you know. It's you
Okay.
get faster. Okay. Now you do the cross. What's next?
Circumference, sir.
Yes. So you go to your FPZ, look, just eyeball it and put a cross on the FPZ. Lagyan mo ng cross yan. Yeah, there we go. All right. Good. So this is what you're going to do. All right. You're going to get your tape. You're going to decide whether you're going to put the tape under the cross or above the cross. Okay. So this is what I want you to remember. This is important. Make sure that you have your own pattern when you measure. So you will not have difficulty. When you put the tape, do you want it on top of the line or under the line? Right? Because if now you go around, if you go under the line of your FPZ, make sure that you are under the line of the T3 and you're under the line of the OZ. You get it? You can go under and then over on the other spots. You have to go you have to make a decision whether you're going to measure under the line or over the line. So what you'll do then is, so you go doing this basically, you're going to go around the head, right? But the most important key here is that when you do that, you decide whether it's under the line of the FPZ. So you will go under the line of the T3 or T4, right? And then you go under the line of the OZ. And then you go under the line of the T on the other T until you go around and reach the other side. Then what do you have? I have 57 centimeters.
Uh,
It's harder
9,
with
ano
the,
po?
ano,
59. 0.5, sir.
Okay, so 60. 60.
Okay po.
All right. So now you have 60, right? Minus
Oh,
57. So now you have 60, right? What you can do with your patient is ask the patient to hold it. Huh? You said, remember? Tell your
okay po.
patient, excuse me, sir, ma'am, when you put this on their forehead, ask them, can you hold this? So when they hold it, you can now use your finger to make sure that it aligns with the T3, the O's, Z, and then around. Let the patient hold it. Okay? You get it?
Okay
There we go.
po.
Good. So once you get that, you have what, 60?
Okay po. Opo.
Now, what you do now is you're going to get 10%. So by 10%, look here real quick. You're going to get 10% from FP1 to FP2, FP2 to F8. So 10%. However, since your marker is in the middle and we're trying to get FP1 and FP2, you need to divide that by half. What I mean is that if your measurement is 60 cm, right? It's 60, paikot 60, no? It's 60.
Opo.
So if you think, calculate it, what's 10% of 60? It's 6 centimeters,
6.
correct?
Yes, sir. Yes
But
po.
so divide 6 centimeters into 2. You have 3, correct?
3. Opo.
So
Opo.
what you'll do is put 3 in the middle of FPZ. Put 3 in the middle of FPZ, right? You're going to do this like this. You put the 3 in the middle and then mark the 0 and mark the 6. Okay? Because this is now, and then just cross it. Now you have your FP1, FP2. Okay? You get it? Because they have their difference, they should be 10% from each other. FP1 and FP2. Okay? It's not 10% from FPZ to FP1. Okay? That's wrong. The 10% is from FP1 to FP2. Got it? So from here,
Okay po.
now you're going to measure now from your, let's say, are you doing the left side? Let's do the left side. You're going from FP1. Make sure that your tape measure is aligned with the T3. Okay? All right? So you can always use your fingers to mark them. So now from FP1, right? And so from FP1 to the left side, what's your 10%? It's 6 centimeters, correct?
Yes, sir.
So now look for that 6 centimeters and mark it. Minus 5.7. So mark it. All right? And just cross it. That is now your F7. Okay? And from that marker, you move your tape measure and you make sure you align it with the T3. And again, you look for your 6 centimeters and mark it. Now you have your official T3.
3.
And now
Opo,
go to the
sir.
back. From your T3, put your 0 tape measure. Make sure it aligns with your OZ, right? And look for your what? Another 6 centimeters. Got it? When you get your 6 centimeters, create the cross. Create the cross. That will be your T, what? That will be your T5. Huh? Got it?
Okay
All right.
po.
Good. So now from your T5, go put your 0, align it with the OZ, and again, find the 6 cm. And that will be your O1. You got it?
Yes, sir.
Good. This is a little difficult because it's slippery. A real patient will be easier because you can ask the patient to hold it. Now you do the same procedure for the other side. So we start with the FP2, make sure it's aligned with the T4. Okay? So from my FP2 to T4, I will hold the tape, and mine is 5.7. Yours is 6.0. I look for 5.7, found it. When you find it, create a cross immediately. And while your tape measure is over there, because the tape measure creates a straight line. So create a cross. Now I have my F8. Okay, you got it?
Yes, sir.
And from your F8, again, you move your tape, your 0, and align it with the T4. And from 0, you look for your 6 cm, right? Minus 5.7. So yours is 6.0. So 5.7, that is my T4 officially. Got it. All right. So now, good. Now you put your marker on the T4, 0. Make sure that the tape measure is aligned on your OZ, okay? And then anchor it. Put your hand there, okay? Put your hand there. You create this. Look at my hand. Use it. So you're holding the tape measure on the T4 and on the OZ. So your other hand is free to measure, to mark. Now I look for, again, you will look for your 6 cm. I will look for my 5.7, right? And when I mark that, I'll create the cross. That will be my T6. Okay? And from there, my last measurement for here, from T6, I put my 0, and then I put the other end of the tape measure aligned with the OZ. I look again. You will look for your 6.0. I will look for my 5.7. And when I mark that, create a cross, that is now my official O2. All right? Wow. It seems a long time, but this is actually really fast. Yeah. So we got our measurement. So now we just did cross and then a circle, right? Cross and a circle.
Yes, sir.
Now, it feels hard, but it's really not. Watch when you have, this is just the first ones. Once you do it with a patient, it's so much easier because mannequins are so slippery, you know? All right.
Yes po.
Now, how are you going to measure perisagittal? You're going to get your tape. You're going to use your pinky. You're going to put it on your FP2, right? The 0 on the FP2, put your pinky there and make sure the tape is aligned on the C3, all right? And then you put your finger there. Now you see my hand? My other hand is free. There we go. Now you're going to stretch that tape to O2, okay? And then measure. What is that? Mine is 24.5. So 24.5
20,
cm. What is yours?
23 po.
Okay, 23. Don't let go. Divide your 23 into half.
Sorry, sir. Ano po? 24.5 po.
Okay, so divided by 2, it's
Um,
12.25, right? Find your
po.
12.25 and mark it. that will be your C4. Mine is 24. Yeah, 24. Actually, I can get away with 24.5. So divided by 2, that will be 12.25, the same. So 12.25 is here. All right. Now, this is all 25%, by the way. So what's half of 12.25? It's 6.1, correct? So 6.1, mark it. All right. And from 12.25, so you basically divide this into 4. So if I was to divide 24.5, right? If I divide 24.5 divided by 4, what is it?
Less.
12.2,
Yes, you
6.1.
did, sir. What?
6.1. So the actual measurement now is this. You will divide it in 6.1. So 6.1 there, 6.1 here, and from here 6.1 again, but you're holding it from the C4 to O2, 6.1. Okay, once you make that measurement, this is the parasagittal. Okay, now look at, you have a line that looks like this. It will follow the contour of the head. Yeah? Now you're going to do the
Sir?
same on the other side. You're going to get the measurement, then you're going to divide it by 4. So 25% each. You're going to go from FP1, you're doing the right. So you're going to go from FP2, and you make sure that your tape measure goes towards the C4, right? And then it goes
Opo.
to the O2. I will go the opposite. So I'm going FP1, I'm going to measure first. FP1, make sure the tape goes above C4, and then all the way to O1. And my measurement is actually 25 cm. So it's a little off, but 25 cm divided by 4 is 12.5, 6.2. So now you can measure then the 12.5 or 6.2, right? 6.2 gives me my initial line, because 6.2 then and another 6.2 towards the back, that will give me my parasagittal. All right. So now, looking at the head, you will have these marks, right? It starts to shape up. You good?
Sir.
Good. The only last thing now is to create our transverse sagittal. So let's go to the front. Let's go to the front. You will put your measuring tape on your F8. Put your finger there, you put your pinky to anchor. Put the measuring tape on the line that you created. Okay, this is your F4. And above the FZ, and all the way down to the F8 or F7. My measurement is 24. I'm going to divide this by 4. So 24 divided by 4 is 6, correct? So it's
Yes
easy.
po.
So it's you're going to divide it in 4. So 6, mark the 6. I'll mark the 12. That's my halfway. Then I'll mark the 18. Okay. If you don't do it that quick, you can go 6, 6, 6, 6 centimeters, right? Now I got my front done. I got my cross. Let me know once you get your cross. Hi, Keziah. Can you hear us?
Yes, sir.
Good. We're doing measurement like your cat. All right.
Yes, sir.
Got it?
Po.
All right. Good. Let me see my view. Immersive. No. Trying to change it to her. Okay. Now towards the back. Let's measure the back. You're going to put your tape, your measuring tape from the T5 to T6, right? But make sure that you go over again, use your pinky, anchor that first one, and then you can use your other finger to make sure that your tape is above or below the line that you created. Okay, and then over the PZ, and then over the other P4, P3, then all the way to the other end to the T6. So my measurement is 26. So if you want to do it quickly, 26 divided by 2 is 13. So I immediately mark 13 so I can get my PZ. Right? PZ is done. So 20, again, what was my numbers? 26. So 26 divided by 4, right? It's 26, 13, 13, 6.5. So from T5, I'll look for 6.5. I hit that. I create now my P3, 6.5. From P3 to PZ should be 6.5. And from PZ to P4 is 6.5. All right. And from P4 to T5, that should automatically be 6.5. And voila. There goes your I-1020. Now we can be EEG techs. You got all your crosses. Oh, there we go. Did you miss any cross? Are you good to go?
Hey, it's a lot.
Yeah,
Too
good.
many, sir.
This is, well, the important thing here is that when you memorize this, when you always do this, you will be ready to do a full RBD montage. You know, if you work for a neurologist or a doctor that says, "Hey, Isa or Keziah or Jeremy, I need to do a nocturnal seizure, study for this patient. Can you do a full EEG hookup?" This is the full EEG hookup. So memorize this, and you can be also an EEG tech. Because EEG techs, this is what they do every time. These are all their spots. Once they finish this measurement, they'll scrub where you create their cross. They'll scrub all those spots, right? And then put the wires, and then have the patient lay down, and then record them for half an hour. The only thing that an EEG tech does is that they'll ask the patient to hyperventilate for 2 to 3 minutes, and then they'll put a strobe light in front of the patient's eyes with their eyes closed, and that strobe light will flicker slowly until it gets faster. After that, um, then they'll just finish off half an hour of recording, and then they wake up the patient. That's what an EEG tech does. the whole procedure for an EEG is 1 hour, half hour for preparation, half hour for recording. So you're potentially at an EEG tech right now. Just memorize this. Got it?
Yes.
So there we go. There's your I-1020. Okay. Keziah, do you have your mannequin? Or you have somebody you can practice with?
Nasa duty, sir.
Oh, duty pala. Okay, no problem. So you can, I'm recording, so you can get the beginning part of this. All right.
Okay po.
Yes, no worries. All right. Now let's move forward to some lecture. Whew, that was a little pressure. That was a little rough, huh? Um, Isa?
Yes, sir. It's difficult because it's no, sir. Slippery.
It's only difficult because it's a mannequin. Mannequin, they're, you know, they're slippery. If it's a real patient, you can, especially look at my head. This is easy because short hair, right? Short hair, and you can just measure, and you can ask the patient, hold the tape. So hold it, let them hold it,
Mhm.
and then you can start measuring,
Yeah,
and
it's easy to measure with the short hair, but when you apply the electrode, it's harder.
oh no, it's when you get used to it. I used to put EEG, I used to do EEG in the ICU. And so the
Mm,
patients are laying down, they can't even move, and you have all these vents, right? The tubing, everything.
mm, mm,
I put a pillow underneath their head so it elevates their head a little bit because they can't move. Most of
mm,
them are unresponsive. And then I'll tilt the head to the right so I can get to the back. I'll measure. Oh,
mm.
I'm measuring. And it's awkward because the patient's laying down and they have long hair.
Hey, sir,
But
how about like that, sir? When it's chemical, it's very hard to put because of the small hair.
yeah, but you can use tape. So you can tape it,
Yes,
right?
a tape, tape, sir. Oh.
I tape it. Tape it.
Mm,
If they're sweaty, then use after you measure or before you measure, you can scrub the areas with alcohol. You don't always have to scrub with alcohol. You don't. You really don't need alcohol. Only when they're sweaty, really sweaty. Okay?
okay, sir. Okay
But
po.
otherwise, when you get used to this, when you get used to this, even your eyeball is more accurate than without you knowing how to do I-1020. Okay, the closer you get to the areas where you're supposed to be marking, the more accurate your positioning will be. So think about this. All right, let's expound on this. Can you see my screen?
Yes, sir.
Okay, so that was already 1 hour of, of just measuring, when in reality, that should take you less than 10 minutes. Um, One of my slowest is 8 minutes. That's because I haven't done it in a long time. But I showed my students, with a real person. When it's a person, it's quick because the person you can hold their head. It's not sliding back and forth. Your tape is not slippery. When if you're using a person's
Mm,
head, you can hold it and it's easy. You know what I mean?
mm.
And then you
Yes,
can
yes,
you can
sir.
run around. So and you can have the patient hold it for you. So that's why this is harder. But when you get used to this, 5 minutes is all it will take to just get the measurement. Once you have 5 minutes, it's done.
Mm,
And then you just
mm,
scrub. When you scrub, it takes you 2 to 3 seconds each spot. Remember that when you scrub with the Q-tip, right? You don't you don't put the Q-tip upside down like this. It
mm,
hurts. It's painful. You go this way, right? And when you scrub it, you don't have to scrub for 5, 10 seconds. No, you scrub. It's the technique is how you press it. When you press it down and you scrub, it only takes 2 to 3 seconds. 1, 2, 3, move. 1, 2, 3, 1, 2, 3, 1, 2, 3. It takes you less than 3 minutes or less than 5 minutes to prep the skin. Okay. So if you finish in 5 minutes to measure, 5 minutes to prep, then you're ready to put the electrodes. Okay. And then putting the
I
electrodes, it depends. As you get used to it, then of course, the faster you'll get. It's okay if you're running a little over an hour for a patient setup in the beginning, but after a while, you should be able to um, mark, measure, and put the wires within 15 minutes, and most of the techs, half an hour, they will finish the whole entire setup in half an hour. And that's decent. That's okay. That's acceptable, you know. But will get faster and faster. The goal is maybe 20 minutes, 15 minutes, then that you're really fast. That means you can set up patients really quickly. And if you don't have a neuro, you have a typical PSG, I can see why most of the time we don't really measure and mark because there's no critical information, right? We're just doing sleep studies. So it's okay if you're not too accurate, right? But if you work for an accredited lab, they would want you to be very proficient with marking and measure if you work for an accredited lab, right? Because you can always get audited, right? When you get audited and they'll ask you questions, and you need to know how to do I-10-20 measurement. This is as if you are a carpenter and you don't have a hammer, something is wrong, right? You need to have a hammer, you need to have your saw, and you need to have your measuring device, okay? Because what do they call it? I forgot what they call it. I'm not a I'm not a carpenter, but they always carry this measuring device. It's on a right angle, but they have to have it all the time. So for sleep techs, you need to get your I-10-20 like in your pocket. Anytime you need it, you know how to do it because it will make, if you do this, if you just create your nasion to inion, auricular to auricular, and then your circumference, you can already have a better baseline because you can see the head better. 20%, 25% of this, you can get the others more accurate when you are just estimating. If you have at least a few measurements in there compared to nothing. Okay, because they will teach you this two finger method, right? This will be your FZ, then CZ, then PZ, then O1, O2, and then C3, C4. Yeah, I mean, it works because you're trying to capture big waveforms and in bigger areas. But if you're doing any seizure montage, any, REM behavior disorder, and full EEG setup, you need to know how to mark and measure. Okay?
sir.
All right. All right. No questions?
Sir,
Yes.
is there a time when they had an audit where you work, they question how do you measure the whole 1020?
Yes, they will do that in advance, and typically if you have the Joint Commission come by, they can come by at nighttime. And at nighttime, they want to see your competency. So they can come in and just ask you, hey, how do you set up your patient? So you cannot show Joint Commission, especially not AASM audit or AASM accreditation, when your lab is undergoing a re-accreditation. You do this every 5 years. You will re-accredit the lab every 5 years, but they will have a site visitor. You will submit your documentations. They will review it, and then they'll say, oh, you passed this, you failed this, you fixed this. So then after you fix everything that's documentation wise, your whole package for accreditation will go through a board. They will talk about this, in a once or twice a month um, um, meeting in AASM, and they'll look at your package to make sure that okay, they meet the requirement, and then they will send you a message, hey, you are approved by the board. Now they will send a person from ASM to visit your site. That's when they will come in and they will talk. Hey, where are the texts? Oh, there's one over there. So they'll talk to you. They'll ask you about your training, and how do you hook up a person, and how do you score a study, right? They will ask all these questions. Sometimes the auditor or the site visitor is very relaxed, and sometimes they're very picky. They will ask you some details. So they just want to make sure that you know what you're doing. And for the most part, if you're an accredited lab, you will have credentialed sleep techs. So you'll have RPSGTs, RSTs in there. Okay. They might ask you for infection control. They may ask you for, do you use and how do you wash your electrodes, right? Do you reuse them? What chemical do you use, etc. Okay.
They were
So
specific, sir.
yeah, ASM they can go specific, but Joint Commission they want to make sure that how do you handle patients' safety issues? How do you handle infection control? Are you up for do you have current BLS, right? Are you scoring? Do you have this competency? So it's more generalized, but ASM can get a little bit more detailed. Okay,
Okay po.
all right. Now. I will go over. You can see my screen? Let me stop share. All right. I want to show some. So what are we really doing? Why are we even measuring, right? What's the importance of it? If you look here, we're covering, so this patient's face is this way, frontal, right? On the left side, and then your occipitals on the back. So questions. Where do you see your alpha activities?
Occipital po.
Occipital, right here. And does your alpha activities react to eyes opening and eyes closing?
Their eyes closed po.
Yes. When you have the patients close their eyes, you will see alpha. Okay. Some patients, they do not have any reaction, but many more patients actually have alpha appear when they close their eyes. Okay. It's a sign of focus, but they're still awake. Once the alpha starts to attenuate or diminish or slow, once they get slower, like, their frequency is what? What's the frequency of alpha?
8 to 13.
8
8
to
to 13.
13.
Yes, 8 to 13 hertz, right? So when you start to say, okay, it's still alpha, and you look closer, actually, it's already 6 to 7. That means that patient's already fallen asleep, right? They start to slow down. It's already theta. It might look a little like alpha, but actually it's slowing down. In fact, this is another point because you can see this on patients that are in REM. The question is, can patients in REM have alpha? Yes or no? What's the answer?
Yeah.
Yes, but how is it different from an awake alpha? Test question. It is 1 to 2 hertz slower than wake alpha. So if you get asked, can you see alpha in REM? Answer is yes. but it will be 1 to 2 hertz slower. Okay? So it will be what? 6 to 7, 5 to 6, 5 to 7 maybe. Okay? But you can see alpha. All right. So it's actually, it will look alpha, but it is still theta range. Okay. You will see alpha in another instance. When will you see alpha, or what they call alpha intrusion? Alpha intrusion. When can you see alpha intrusion?
Age entry, sir.
The answer is, well, alpha intrusion means that you have alpha on N1, N2, N3, and REM. Alpha intrusion means you have alpha all the time.
All the
And
time.
so why would you have alpha all the time? And the answer
Medication.
is yes, correct. If the patients are on some type of medication. So typically if they are on stimulants, they can have induced alpha. So it's very difficult to score those studies because how can you know when the patient's going on sleep onset when you see alpha the whole time?
Yeah, correct.
That's yeah.
Yeah,
So
I've seen one
yeah,
those
so
episode. Yeah,
that's good if you've seen them because you have to familiarize your eyes. You have to keep looking and what's the difference, And then that's why it's important to understand the signatures of the different stages. What are the signatures of different stages, right? And let me just briefly remind everyone, when you see N1, what are the signs of N1? You will see what? SEM, right?
Sam.
Slow eye movement. Exactly. SEM, right? And you will see a drop in the chin tone. You will see a small drop in the muscle tone. So if you see eye rolling movement and then the chin reduced, not completely gone, but just reduced, that's another parameter or parameters to identify N1 sleep. Now, once they get into N2, if there's alpha intrusion, but look behind the frontal region to see if you have any K complex, right? Because it's very difficult to find spindles if you have alpha, right? But you might still be able to identify some K complex on the frontal channel. Because what's on the frontal channel right here are your K complex and what?
Delta.
Delta and slow wave sleep. All slow on the front, slow activities, faster activities at the back, right? Central area of the brain will show the not so fast, not big, but smaller. And what shows up on the central part of the brain? You got the
Spindles.
spindles, you got the vertex, right, could be it could be negatively negative deflection or positive deflection. Okay, it could be upside down. So there's your vertex. It will look like a spike. Okay, and it's typically around central. You might see it on other areas, but they emanate from the central region. And then as you go towards the back, then you're talking about alpha frequency. So it's faster, right? And some patients, especially if they're on really high stimulus, you will see beta or beta activities, which is faster than 13 hertz. So they're really, really, really fast. Okie dokie. That's why when you put and utilize your I-1020, you properly mark and measure, you will have better definition, right? You will have better defined waveforms, right? Because you put your leads closest to where these waveforms actually come out of or emanate from. Does that make sense?
Yes, sir.
All right, good. And since we're talking about hookup, what again is your impedance? What's the
5
allowable?
kilo ohms.
5 kilo ohms. Very good. Okay. 5 kilo ohms, it will allow for you to see good waveform. If you have really high impedance, your recording will be blurry. Your recording will have a lot of artifacts, and it can show a lot of maybe 60 hertz artifact, or it will just be very dark. It's not going to be clean. Okay, it's more prone to picking up other artifacts. That's why you have to have lower impedance. That will save your recording. It will look nice and clean, easy to read, easy to score. Okay. Aside from impedance, then there will be techniques on applying. Let me pull this up. All right. Can you see my screen now?
Yes, sir.
Now, this is okay. I don't see the ground. Okay. And the ground doesn't have to be right in the middle. Okay. Why do we put the ground here? Why? See, for me,
Stable.
I have a big forehead, so you can put the ground anywhere. This is all ground right here, big ground. An airplane can land right here.
Hmm.
So the idea is what? Stability, and that you have a bone, a skull there, right? Right here, when you put your ground here, it can be flat. You can even tape it longer or bigger so that it will not move. If your electrode moves, you will create movement in the recording. So remember that. So when you use your ground and your reference, right? Reference, you're going to put it at the back of the ear. Why do we put it here, right? This is a mastoid. Why? Because it's flat and it's bony. You don't want it to pick up EEGs. You want the bone. The bone will reduce the electrical activity that it can pick up. Okay. That's why we do that. Okay. So sometimes the systems will have a ground and a reference and then A1, A2. So you have four total like reference that are attached to your active electrodes. So your active electrodes are what? Active electrodes are always the one on the left side of the chat of the montage. C3 to A1, C4 to A1, right? The C3, C4, those are the first mentioned leads, meaning to say those are the active leads, okay? And the one on the right side, say C3 to M1 or C3 to A1. The A1 or the M1 are your reference. So you're really collecting from the active electrodes. You just need to refer it to that reference point, whether it's A1 or A2, right? Because to create a wave pattern, you need 2 points. And the way to just remember is that why do you need 2 points? Well, how can you have how can you have a how can you hang your clothes? How can you hang your clothes if you don't have a line? And the only way you can have a line is if you have, how can you have a sampayan, right? If you don't have two spots to hold onto that line. That's why you have an active electrode and a reference electrode, so you can create that waveform. It has to have two ends to have a line. If you only have an active electrode, where's your line? Where's your channel? It doesn't, you can't. Okay. Especially for EEG. Now for EKG and EMG, you can just create, you can just refer it to the other. That's why you have two leg leads on each leg. Now, look here. If you look here on this patient, this is good that you have anchored the cannula and the thermistor or thermocouple, right? It's anchored. My problem here is that it's anchored higher up. If this patient itches, she can quickly pull this out. When she pulls this out, it will just be sitting outside her nose. If you anchored the pressure transducer and your thermocouple, anchor it down here so it becomes a line. Even if they itch, if they move it, it's still there. It's not gonna go anywhere, right? Because if you anchor upwards, so she pulls it up, it's gonna go up. But if you anchor lower and you create like a straight line on the nose, even if they touch it, it's gonna be there. It's gonna pick up activities. You get my point? Because they can't yank it up. It's not gonna go up because you anchored it here. So that's just one advice. Okay. And for the snore, right? The way you do snore is when you touch the Adam's apple, you ask them to go hum, like make them hum. You feel the vibration here, right? On where usually you palpate. If the patient is sick, right? You try to palpate for the lymph nodes, but feel it there. When you're talking, it vibrates a lot. Hello, 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 test, 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 mic. You feel it. That's where you put the snore microphone because you will get a good signal, right? Any questions? And lastly, if you see this electrode right here on the right side? What is that?
Yes, sir.
Is that the proper position
Mm,
for chin?
No.
It's
no,
not.
sir. Too, too
Will this
far.
but will this work?
Okay.
It will.
It will?
It will. When you bite, because it's for bruxism, right? When you bite, this
Mm,
entire muscle is engaged. It'll pick up. In fact, look at people that bite down. You'll see this muscle pop, right? When you bite down, try to bite down. You feel this muscle get tense. So when you put an electrode here and here, you will still pick up grinding of the teeth or bruxism. Okay? I like to do it this here, especially if I'm doing CPAP titration, right? And I don't want anything on their face. Like maybe I can use a full face mask. If I use a full face mask, then I don't have to worry about any tapes here or what have you, right? I'll put the electrodes here. Sometimes you'll require two and one because the proper placement is, of course, the chin Z, right? You put it on the chin and you go underneath the chin is 1 centimeters below. That's chin Z. Then you go to the right, 2 centimeters to the right, 2 centimeters to the left. Then you have your three electrodes for your chin recording. Okay. Hi, Aisha. Welcome, Aisha. This is our first session. So, excuse me. Now, there's a reason why we have all these wires dangling, but I don't like it like this. I always bundle the wire after I gather them and I pull it to where about 6 inches from away from the hair, and then I start to wrap it. So I have a ponytail. You will never see me with wires that are scattered like this. I don't do this. Why? You have a big chance of the wires getting pulled. You have a big chance of this wire picking up electrical activity somewhere. If this patient has her cell phone underneath her pillow, it will pick up. It will pick up 60 hertz artifact. Excuse me. Okay. Any questions? Now, your most difficult patient, of course, is your is the pediatric, but not all the time. Some patients are very difficult. But with pediatric, you can always use more tape or you bundle it, right? So if you look here, you don't see the wires just everywhere. the tech bundled it at the back of the head. And in fact, it's behind the pillows. But when you do that, make sure that there's a lot of slack. Because if this patient moves forward, it will pull on the wires. But if you notice, the hook up here is mainly these sticky pads. And these are very strong because they're EKG. This is like you can use this for EKG or EMG, but obviously here they're using it also for EEG. The impedance will be bad. I mean, the impedance will be bad. Look at that. It's all just pads. It's the lazy way of doing things. But for pediatric, I understand because pediatric can be very, very difficult, especially if you scrub the patient and makes it very difficult. All right. And some kids you have to really wrap their heads. You have to wrap it. Like look at this. This patient has Down syndrome. You can see it. Excuse me. Now, what can you
Sir,
tell me?
it's
Go ahead.
eh, sir, it's very difficult, sir, when it's a special case on
Yes.
hooking up. And
Yes.
pedia patients who are they are afraid already of hospital staff because there might be injection or something.
Yes. And poor little kids, you know what I mean? They're so tiny, they don't know what's happening. And then if they have Down syndrome or retardation, they really are like, what are you doing to me? Are you gonna hurt me? And so if you can see, there's no measuring here, right? Look how close these
Yes, sir.
electrodes are. What is this? This is not even
Pleasure.
like F7 and then you have a C3.
Let's see.
It should be F7 is somewhere here, but you don't even use F7. You should be up here. This should be an F3 up here, then C3 right here. And then,
Mm,
okay. And this is wrong because this is now closer to a T5, right? Again, let's pull up
yes.
um, just for Aisha's sake, as I can show this. Aisha, can you hear us?
Yes, sir.
Good. Welcome to the class. We're talking about marking and measuring the head. So this is when you hear me say, oh, T's, PZ, FZ, C3, C4. It's only it's only the acronym for when you say C, like central, right? Central part of the brain versus an FZ, right? Is frontal, and you have FP or prefrontal, and you have O, occipital, and you have P, parietal. So this is what we were talking about here. And anything that's in the middle is a Z. So FPZ, FZ, CZ, PZ, OZ. Anything on the left side will be an odd number, and anything on the right side is an even number. That's why you see here it's F4 on the right side, C4, P4. These are just the locations of the electrodes, okay? So obviously, if you look here, and this is very organized, so this is the correct way of marking and measuring. Obviously, with a pediatric, it's so difficult, right? So it's so close. I mean, you will not get really good studies here, but the beauty with pediatric is that their skull are very thin. So guess what? Their EEGs are very big. They're very big. You will not have difficulty picking up an occipital A1 occipital alpha activities. You will not have difficulty picking up delta, low amplitude mixed frequency, K complex, sleep spindles. All these waveforms will be very, very visual or distinct because they have such a small and thin skull. So their electrical or the EEG patterns will come out easily. Okay? When every time you do a pediatric, you'll see you have to reduce the waveform, make it smaller because it's all big. Okay, simply because they have a thinner skull. And here you always have, see, it's covered. You're supposed to have an electrode near the eyes, right, to measure rapid eye movement sleep, correct? So it's typically 1 centimeter outside of this corner. This corner of the eye is called outer canthus, canthus, canthus. You measure 1 centimeter out and then 1 centimeter below. That's your left. For the right, 1 centimeter to the right from the corner of the outer canthus and 1 centimeter up. Okay. But of course, it's difficult. Sometimes the way the patient's facial structure is too close to the eyes. So you have to move it a little bit. It's another 1 centimeter. But if you're taking the test, it has to be answered precisely. You cannot say 2 centimeters is okay. No. When you're taking the test to get your license as a sleep tech, you have to be precise with your answers. And so it's different when you take the test and different when you're actually doing it, right? All right. And so when it comes to the EKG placement, right? You have your clavicle bone. Of course, you go at left and right side, but the proper way to have a really good, say, morphology or shape, um, a good shape for your EKG recording is if you have the right side, so you'll go 2 to 3 inches from your clavicle bone, you put your one lead there, and then you can, if you use 3 leads, you can put the other one on the left side, same place, and then mid-axillary. You're talking under the armpit, 3 to 6 inches, right, on the left side. Okay, you can put it a little closer to the front, right? But if you have that pattern, your PQRST will look better. It will be bigger and it will give you a better morphology. Okay. So, good morning. Sometimes the patients are too hairy, right? When the patients are too hairy, then you can really shave them. And sometimes if the patient's just hairy on the front and they don't want to shave, you can use the back. You can put 2 EKG pads on the back and it will pick up. I've done it so many times. You can put it on their back. It will pick up because EKG is very strong. The EKG activity is pulsates very, very strongly. Some patients are very difficult. And some patients, the other problem is they will have sensitivity, right? When they have sensitivity, um, then they don't like the sticky portion, but you don't have a choice because there's no way on getting activities or recording without using those pads. The least you can do is maybe replace the sticky pad and use any EEG, put a little bit of paste and tape it. So you use a smaller tape instead of the actual EKG pads. You'll still pick up the same activity. Okay. All right. Any questions so far? Any questions so far?
Not so important.
All right.
Oh,
So, go ahead.
answer.
No? So since we are in the topic of we're in the topic of sleep and EEG and I-1020, right? I'll show another picture here. This is not mine, but I'm pulling it from the internet so we can have a discussion. All right, everybody see my screen? Everybody?
Yes, sir.
What system is this? Anybody familiar with the system? This is the Alice system, okay? It's Respironics. Can you tell me if the placement is correct? Anybody? How's the EEG looking to you guys? I think
Correct. Correct,
it's
sir.
a it's I think the ground, I don't think the tech measured because the FZ should be around here. The FZ is typically closer to the hairline, okay? And from there, you're gonna count, you're going to count F7 and F8 usually at the corner of your hairline. They always fall towards the temple area. And so in between your FZ and your frontal F7 and F8, in the between them is your F3, F4. So this is a little too far back. Okay, it's closer towards the central than to the front. You agree? So this tech didn't measure. The central is a little too low. Usually central electrodes are a little bit on top of the head. And then here, if you look at the eyes, this is not above or below. It's right on the same level as the outer canthus, right? And if this is on the left side, it should be low. From the left outer canthus, you go 1 centimeter to the left, and then 1 centimeter below. And for the right side, 1 centimeter to the right, and 1 centimeter up. So this obviously the tech did not measure and put it on the right spot. Then lastly, I can tell you that the chin is not on the right placement. You do not put chin here. You put this below the chin, right here, underneath. Okay. You find the middle part of the lip. That's your chin Z. This is your chin, right? And you go underneath, posterior. Underneath that 1 centimeter, so you're under the jaw. That's when you will get 2 centimeter to the right, 2 centimeter to the left. That's when you will have your chin one and chin two. Okay, that's the appropriate placement. But then again, you can modify it if you're not doing this and you're not being tested, it's okay. You can even put it here, right? You see that in front of the ear, there's always a space where there's skin and there's no hair. That's where I usually put mine because if you bite down again, if you bite down, you this muscle picks it up, right? The mandible, the masseter will pick it up. So muscle activity will show up. Try it. Those that are already in the sleep lab, try it and then tell me. All right. Questions? Wow, we're going long today. 2 hours. Now, I will mention a couple of other things and then we will wrap up because um, I really just want to make sure that you guys get the I-1020. And again, I'm recording, so for those who came in a little bit late, you will get the link to the recording of this lecture. So don't be concerned. Now, there are some studies that require more electrodes, and typically when you do research or you do like traumatic brain injury patients, after you put your initial I-1020, you will add in between electrodes, in between all the spots. And it's very time consuming, but when you deal with a neurologist and you're doing research or you're doing traumatic brain injury patients, you can end up doing that. And it takes a long time, but just so you know. Okay. But here again, when you hook up your patient, never do this. This is this is a disaster waiting to happen. Okay. What can you tell me about this hookup? Can you see?
Sure,
Yeah.
the patient may get tangled.
Yeah, it already looks tangled right now. So you can you can even buy there's a tube buddy or they call it a lead or electrode. It comes with a zipper, but it's a long is a cloth and you can
Yes, sir.
Yeah, and you can put all the electrodes inside and it has a zipper, so it becomes like a ponytail. So it's not like this, because this, the patient can turn and can easily pull on any of these electrodes. Okay. And usually I put it a ponytail towards the back of the head and it lines up on towards the neck. Okay. Because if you create a ponytail and it's right behind the head, they will lay down on it. Imagine that. So it will create artifact. When you create a ponytail, go towards you pull it, pull the wire, but create at least 6 to 8 inches away from the head so that you put that underneath the neck. Our neck has a contour. So even if you lay down, there's a space there underneath the neck, right? So it doesn't press on the electrode. So they can turn left and right. And because you have this contour, it's not going to press. And you will have less chances of the electrode getting pulled. So when you prep your patient well, take your time. It's slower, but you have more stability recording all night. Instead of you can do this quickly, but you have a very messy setup, then all night you're troubleshooting. The electrode popped out of the patient's head. You go in there, fix it. You sit back. Oh, another electrode because you rushed. Make sure you take your time, but you make it neat and you tape appropriately. Then you won't have less troubleshooting issues all night long. Okay. And when it comes to pulse oximeter, right? This is a NATO system, by the way. I can see by the color of the head box. That's what we have right now in USC. And this is the VPAP TX. This is ResMed titration system, right? This has all the modes from CPAP, APAP, bilevel, ST, ASV, and even VAPS. Okay. When I put the pulse oximeter, I don't use the index. We are used to picking our nose, scratching. The weirdest finger to use when you're not paying attention is the ring finger. I always use the ring finger because you don't scratch like this, do you? You don't pick your nose with the ring finger. It's odd. So it doesn't get used as much. And it has a big nail bed. When you're doing pulse oximeter, you want a big nail bed. So to pick up a better SpO2 reading. So that's why I use the ring finger. And when you put the ring finger here, and I always put another tape here. So then make sure the patient can fold their fingers before you put the tape. Because if you put it too tight, they can't move their finger. It's uncomfortable. So put the tape, the pulse oximeter, and then make them move their finger and then tape again here. When they're moving around and they get caught, it will pull on this anchor. It's not going to pull directly on the pulse oximeter. Reduces your chance of troubleshooting. So you maintain a good reading all night. You got it?
Yes, sir.
All right. So any questions? Aisha, Kizaya, Isa, Jeremy, any questions?
Not, sir.
All right. If none, then I will end here and I will talk with um I will talk with Aisha.
Okay, sir.
No more questions. Jeremy, I think is working tonight.